So, okie dokie. Welcome back. Everyone seems to have found everything, so that's good. So I know that from those of you I've been meeting with, some of you have been able to do the first SGA, which is great, the first study guide assignment. Today, I'm going to have you all just introduce yourselves again briefly, and then mostly so I can take attendance, but also so y'all can start to get to know each other's names as well, if you don't know each other. And then we will do a quick review of Blackboard, and that's not on full. And then we will start delving into some of the questions from the SGA. So, alrighty, I'll have everybody go around and say your name, and then just like some factoid you know about the brain, and it could be something you learned from the readings, or it could be something you already knew. So we'll start here.
Debbie.
Sorry for not putting you on the spot with the backwards.
Oh gosh. There was something I was reading that I thought was really interesting, but on the spot, exactly what it was. One of the things I thought was really cool was that system of like blood vessels and stuff. You can, like, if something is not working, your brain will like reroute around it to reconnect to something. I thought that was pretty cool.
Yeah, our brains and our bodies in general are much more adaptable than we tend to think they are, and the brain in particular wants to keep functioning, right? So it will reroute if it needs to. Yeah.
And fun fact is the gray matter in the brain is in Latin known as arbor vitae, which is Latin for tree of life. Because if you were to completely bisect it and lay it out, it would sort of.
Oh, that's really cool. I should have worn. I have a brain necklace. I'll wear it one of these days, or you can kind of see that.
I really forgot that. I thought it was really cool from the reading to just go over all the different parts of the brain again.
Yeah, definitely. That can be really helpful.
I was thinking that I still want to go into medical field, so I guess it's most interesting for me seeing the connection between the clinical and the research side of this, and how studying the damaged brain gives us insight into a healthy brain and vice versa. So we have to study both to understand.
Exactly. Yeah. You know, it's not ethical for us to purposely give people brain injuries whenever we want to, right? We do it to rats and other animals, but we're not going to do it to humans. So, you know, we work with what's there.
My name's Sophia. Just from the reading, it's nice to know like all the different scans of the MRI because I've had an MRI done just to know like to see what it like does and everything with the different.
Yeah, we're definitely going to go over that today. So it's awesome.
I'm Amanda, and I guess one of the things that I thought was see in the first chapter was just all like the anatomy, like it brings back the fun of anatomy class. And I had like all the whole parts of the brain, you know, the disorders.
Yeah.
We're going into a lot of detail like that.
Definitely. Yeah, I did not end up specializing as much in neuropsychology as my friend Anya did in grad school, but because she went that direction, she actually took a weekend in grad school and went and dissected the human brain. So she got to learn all of that. So
I went to college, well, not to university, but they're one of the only universities community that has a cadaver lab. And we got to hold a cadaver from a man who had a severe brain deformation.
Oh wow.
He had a tumor that just kept growing, and he was already very he was special needs, and so if they didn't notice he was moving fast enough, they just thought that it was the normal and not abnormal for him.
Right.
And when he died and they were able to look at his brain, the tumor had left a hole in his brain tissue that was deeper with it.
Oh, geez. Yeah, I think that's a really important point when Miranda just brought up. A lot of times with folks, even things like Alzheimer's, like we really don't know the extent it affects on the brain until afterwards when we do an autopsy. Like CTE, the disease that affects people with multiple head traumas, like football players. That's another one that we can't even like technically diagnose until the person is dead, even though we pretty much figure out that's what's going on.
I'm looking and like I said, nice to like relook over some of the
Nice. Yeah, it's so cool. And then we'll talk later on about like what happens when you have to sever it and all the things that happen in your body then.
I just really like. It kind of looks like the back of an eyeball.
Right.
You can really see what's in the eyeball.
Yeah, if anyone has the option and you can afford it when you go to the eye doctor to have them take the picture instead of dilating your eye, it's like the coolest thing. You can actually, like, especially for someone who's like a psych major or interested in biology, like you can see where the optic nerve leaves the eye. You can see the blood vessels. And apparently the blood vessels in your eyes can be like an early indicator of if you're going to develop hypertension or high blood pressure elsewhere in your body. Very, very cool. Yeah, I think my eye doctor charges like 20 or 30 bucks to get it, but it's like worth it every time because I'm just like, let's see it. All right. Yeah. I mean, they do it in like really rare cases, but yeah, there are cases where people have hemispherectomy, they call it, or they take off half the brain and they can still function.
I will, and not in the clinical season, but I saw that the page would be, different parts of the brain for way longer than I should have. I was laughing at the fact that, and at least two languages that I know of, cerebellum, the little translation for the word for that is little brain.
Nice.
And I found that far more than that.
Nice.
I've done 2 movies and
Yeah, I mean, that's something we'll really talk about a lot. So lateralization does exist. There are different parts of your left brain that do like more language stuff, for example. It's not to the extent that like the left brain, right brain miss, right? You're going to only use one side, right? So that would be bad if you didn't need to have it removed, right, for seizure purposes. But yeah, if certain parts of the brain, if you have an injury or a tumor on one side, it might affect totally different functions on the other side.
I didn't know that was near the microphone.
Yeah, oh yeah. Everything in your body can affect your brain. It's amazing. Things like, how much sleep you're getting, how stressed you are, what's happening in your gut, what's happening in your heart, all those things can they all interact. Yeah. Right. Yeah, and lots of primitive cultures did that type of like drilling a hole in the skull to let out evil spirits, right? Yes, trepanation. And even I think everyone's graduated from on the trip back in 2017. We took a trip over J-term to London, Paris, and Amsterdam with psych students. And when we were in London, we saw one of their medical museums. So they even had like a mock-up of the skull where they practiced it, which is like a little mind-blowing. So, even in like the 17 or 1800s, they were still doing some of that. Yeah, that's a lot of what we call neurological disorders or psychological disorders have to do with these imbalances in something as small as neurotransmitters. So, and it's so interesting how like the same neurotransmitter that's implicated in ADHD, for example, is also implicated in like depression, in different ways. And they all interact in different ways. So yeah, we'll talk a lot about neurotransmitters and how when those are messed up, right, it's gonna cause a lot of problems. Yeah, no one believes that, but it's true that when you're multitasking, actually what you're doing is you're shifting your attention very rapidly. And no one does it particularly well. There are people who can like get by with it more than others, but it's actually a lot better if you like do one thing at a time. All right. Yeah, definitely. So not only genetic things, but different things can happen in utero. You know, we commonly think of things like fetal alcohol syndrome, right? Or even drug use, but something as simple as the mother having the flu while she is pregnant can actually affect fetal development. And there's some suggestion it might even be linked to things like schizophrenia. So, you know, everything can affect it.
Specifically the flu or just
I think viruses in general. Yeah. Yeah, definitely. We're not always good at that. Yeah, and it takes longer to learn things. Is anyone in here over 25 besides me? Okay, couple. Your brains are done developing. Everyone else in the room, your brains are still developing. Your brain keeps developing until you're about 25. Especially the prefrontal cortex, this part right here, is the last part to develop. And so that has to do with things like inhibition, organization, and this is one of the reasons why they think like teenagers don't always make the best decisions. That part of the brain's just like not fully formed yet. And then of course, once you hit 25, you immediately start at least a little bit of cognitive decline. So woohoo! What I'm trying to do is, for some reason, this is reading like I'm going to do like a PowerPoint presentation. So I'm basically trying to tell it, no, I want you to actually do this correctly. So no, I do not want to extend the displays. Duplicate the displays. That's what I want to do. Whoa. There we go. Okay. I don't know if you all saw it, but I got something very psychedelic for a minute. So it's like, that was not expected. Okay. This is not the optimal screen resolution. I don't care. We'll see if it bites me again. Okay. All right. You know, it's always an adventure when it comes to technology in the classroom. So quick walkthrough of Blackboard here, and then we will really dive into the information. So hopefully y'all have found the SGAs. I haven't done what I would typically do and look over them to look at questions and kind of made my lecture based on that, just because for this first one, I'm going to cover the same stuff no matter what, just to like give you a baseline. But by next week, I'll be really structuring what I talk about based on what people have questions about. So make sure that you are doing that. So you can always find a copy of the syllabus here. And then my info, links and videos that I'll show throughout the semester are here. And then the book PowerPoints are here as well. And then I think that's all you really need to know for now. Here's where all your SGAs are for the semester, and they will stay there for the semester, which is nice. So let me go ahead and start by really just chatting. I'll start by chatting instead of pulling anything up. So based on reading over the syllabus, looking at these first readings, what is clinical neuropsychology?
In the book, it says that it's the study of human behaviors, emotions, and thoughts and how they relate to the brain, particularly the damaged brain.
Exactly. Yeah, we're really looking at the study or the relationship between brain functioning in all the different ways Miranda just said, and also behaviors. And again, whether those behaviors are typical, normal, right? I don't really like those words, because as we dive in more, you'll discover there is much more variation in normal brain functioning than we typically tend to think. And then, mostly we look at the abnormal or damaged, different dysfunctional behavior that relates to the mind and the brain. So clinical neuropsychology has a goal to understand human behavior, and particularly as it relates to the brain. And you can have both applied and academic neuropsychology. So what's the difference there? So what would an applied neuropsychologist do, or a clinical neuropsychologist? Yeah.
So working with patients doing assessments, sometimes we do treatment, whereas academic would be more doing research and stuff like that, and I think the personal is more for the purpose of.
Exactly. Yeah. And there are neuropsychologists who would do both functions. I don't want to say like everyone only does one, right? Or what would often be more common for an academic neuropsychologist is they might supervise students who are doing the type of clinical or applied work of assessing the individual for the treatment of that individual. But yeah, so in applied, you're working with a person one-on-one. You are hoping to diagnose them and also hoping to help come up with a treatment plan for them. And then in academic clinical neuropsychology, you want to learn more, not only about the damaged brain, but essentially how the normal brain works by studying those who might be having these struggles. So just to give you sort of an example to sort of differentiate this. So my graduate neuropsych supervisor, Dr. John Dunstead, he would supervise us when we saw individual clients who came in to get assessed for, let's say, memory problems or ADHD, things along those lines. But then there were times where we would help him collect data for research, and we might be doing some of the same assessments, but we're not using that to like diagnose an individual. In fact, most of the time the individual wouldn't get any feedback on that assessment per se, right? Because it was just going into a larger de-identified data set. So I actually helped him do a study and have a manuscript that's published off of this study where we brought in folks, I think they were like 65 and older, and had them do a series that was kind of like a mini version of like the presidential fitness test, if people remember that from high school. Like one that was appropriate for older adults to do, including like various strength things, and they had to like walk laps around the gym. And then we also did these neuropsych assessments, and then they also did blood samples. So it was a really cool interdisciplinary study with people who were expert at doing all those various things, right? So we weren't the ones doing, there were people from the physical therapy department having them do the things for their muscles, for example. And what we were partially looking at is a compound that exists in our brain called amyloid beta that also shows up in our bloodstream. This is one of the things that's been linked to Alzheimer's. It is there, you may have heard of like plaques or gunk that build up in the brain. Typically, at least a good chunk of those is made up of amyloid beta. And so what we were kind of looking at is if people were more fit, so if they were like keeping more active physically, did that affect the amyloid beta in their brain? Did that affect their performance on these neuropsychological tests? And it did. So there really is, we're going to keep coming back to this mind-body connection, right? So not only, you've probably heard of like do crossword puzzles or Sudoku to keep your brain in shape, but if you just like keep yourself physically active, and it doesn't have to be Olympic athlete level, right? Literally, these people are just like walking laps around the gym and doing okay. Then you can actually improve your chances of delaying the onset of Alzheimer's or being able to cope with it more. So really interesting. So in particular, neuropsychologists look at how brain change affects behavior. And kind of as Miranda hinted in her answer, we kind of do that backwards, right? So we're looking at behavior and we're testing behaviors in different ways. And behaviors don't have to be things like walking, right? Or, doing some sort of activity. Behaviors can be remembering things, right? Drawing, writing, different tasks we would have them do. So it incorporates things like anatomy, chemistry, physiology, obviously things as you branch out like typical psychotherapy, so mainstream psychology, whatever that is, pharmacology, even philosophy. And philosophy really influences psychology in general, to be honest. But in particular, it's really about thinking about, I hate to use the word prove because we don't ever really prove anything in science, but finding support for ideas that philosophers philosophize essentially by doing this type of research. So there's lots of really cool and some of these become like buzzy New York Times sellers, right? Like one of the books that was out a few years ago, was like Thinking Fast and Slow. And that's like ideas from philosophy that they found support on through neuroscience and neuropsychology, right? So actually thinking about the ways the brain works and those coinciding with ideas we've had about the mind for centuries, but just haven't been able to empirically test, right? And it's an interesting dynamic, right? Because I think even if you talk to most philosophers today, none of them would be like, well, I want to go out and do an experiment. That's not all of them, right? But certainly a lot of them are like, no, I want to like write and think and teach. And whereas psychologists are like, let's figure this out, right? Let's figure this out in an applied way. So it is distinct. Obviously, we draw from neurology, which is biological and medical, and also cognitive science, which again, mostly has its home in psychology, but also is interdisciplinary in and of itself. So cognitive science is things about thinking, things about memory, attention, a lot of the functions that we test to see whether or not they're damaged when we're engaging in neuropsychology. Alrighty. So in order to be a good clinical neuropsychologist, what properties or aspects or knowledge do y'all think someone would need to have? Yeah.
I think they have to have deep and enough skills to be able to properly communicate with people.
Yeah, so A, just basic communication skills, right? But B, yeah, in order to be a good clinical neuropsychologist, you have to be a good clinical psychologist, right? You need to have that basic training in how do you interact with people, how do you put people at ease, right? How do you assess even things that are sort of normal in psychology, like a background, right, of things. So yeah, and the vast majority of clinical neuropsychology PhDs are actually housed in clinical psychology departments. So there are some specifically neuropsychology departments or degrees, but typically what you will do is you get a degree in clinical psychology, but you just specialize in neuropsychology. And then You would do the same training as other clinicians. But then when you got to like doing your practica where you go out and see patients, you would try to find a neuropsychologist to work with for that. And then you would, on your last part of your PhD in psychology, so a PhD in psychology is typically 4 to 7 years. The average is 6, which is what I did mine in. And your last year has to be an internship, which is I refer to as my residency to non-psych people because they understand that better. When I say internship, they're like, oh, that's cute, you did an internship. No, it's like 60 hours a week. But it has to be a like full year of really immersed in clinical work. And so you would strive to find one of those really focused on neuropsychology as well. And then what a lot of folks do after they get that PhD is they'll go and do either a research or a clinically based postdoctoral fellowship. So if you've heard of a postdoc, right, that's what that is. And so that might be 1 to 3 years as well. And like I said, those can be research-based if you're thinking, I want to be more the academic side, or that again can be more intensive clinical training. And so a lot of people will use that to get licensed because often states require additional hours after your doctorate to get licensed that are supervised. Virginia is not one of them, which is nice. And Ohio, I think, are 2 of them. But also you just get training you couldn't get during your actual program. So typically, if you're going to be a neuropsychologist, you're looking at bare minimum 4 years of undergrad, and then probably 5 or 6 years of grad school, and then potentially another 1 to 3 years of postdoc before you get your first like job done. So it's a commitment, but so is getting a PhD in general, right? So there are certainly people who are clinical psychologists like I am, who go on and do postdocs as well. So if I had wanted to practice, I would have probably chosen to do a postdoc in, say, like an inpatient eating disorder setting, because I never got the chance to have that experience. But because I knew I wanted to teach and I felt like I had all the research training I needed, I was able to come right here after I got my PhD. I literally got, they call it hooding when you get your PhD. So I got hooded a week before I started this job. So like I snuck in there. I don't know if I'd be able to be hired now. It's getting harder and harder as, you know, with the economy, places aren't having jobs, right? And then so you've got the same people on the market year after year. Well, you've got new PhDs coming out. So there are people who, like Dr. Ariel did a research postdoc before he came here. And more that's becoming the norm, even being hired at a place like a liberal arts college. So I don't, hopefully they would have still hired me, but I don't know. Right? So yeah, it's a lot of commitment. It's a lot of training. But you get to do some really cool stuff right after that. You get to either practice or do research or both. And you are in the position to run your own lab, run your own clinic, that type of thing. So regardless of which direction you choose, right, either being like here in town, there are several neuropsychologists who just have clinics, like there's one off Pleasure House. I looked them up one time and they have a dog on staff, so you know, that's pretty cool. Or, you know, if you're going to be someone like Uber at EVMS, there are several neuropsychologists on staff who mainly focus on research, right? Either way, you need to be aware of the interplay between the academic side and the applied or clinical side, right? So even if you are a pure researcher in really any part of clinical psychology, but particularly something like clinical neuropsychology that's so applied, like your participants will be people, right? So it's not like you're going to be like, I'm just going to study, you know, like some dust rolling by, right? I mean, like there are biologists who do that and find really important things out, right? But so you need to, as Will was saying, have those basic clinical skills. Also, if you are one of those people who's out there practicing, you have to keep up with the latest literature. So when new versions of tests come out, for example, you've got to get trained on them and purchase them, because if you keep using the old one, you're doing your clients a disservice because it's not up-to-date science, right? You need to be up to date on what are the new developments in things like, let's say, Alzheimer's disease. Maybe there's new diagnostic tools, maybe there are new treatments, right? You need to be aware of those so that you can either administer them or have referral information for your clients. So you need good research methods. Basically, I know some of you are in my scientific literacy class. Essentially, you need good scientific literacy in general. So these folks work a whole bunch of different places. So as I mentioned, they can be in an academic setting. They can be in an inpatient setting where they would work with people who have, just recently had some sort of brain injury, for example, or maybe even can't be independent because of their brain injuries. They can work in psychology departments, neurology departments, psychiatry departments, even rehabilitation departments. Like I mentioned, they can be in private practice as well. So they can be in hospitals, VAs, all kinds of different settings. And they're involved in diagnosis and assessment primarily, but as a couple of you have mentioned, they also will be involved in treatment as well. Each person that comes to you can have a totally different constellation of things, right? And this is true of clinical psychology in general. Like, it's pretty rare, especially when you get people with more severe psychological issues. So for example, when I was treating people with eating disorders, it's pretty rare for someone to come in with just an eating disorder. If you get to that level of your mental health affecting your physicality, you're probably also struggling with maybe an anxiety disorder, a mood disorder. Many of my clients had suffered trauma, particularly sexual trauma. And the same thing with neuropsychology, right? If you come in with a memory problem, whatever is affecting that is probably going to affect other functions as well. And you also need to be aware of clinical psychology because of that, like, mind-body connection, right? That struggling with these things can make people anxious or depressed. And sometimes these symptoms of the brain injury, right, can be depression. And for example, in older adults, we really need to make sure when they come in, we parse out depression from dementia, because they can look the same on some of the ways people score on tests. So when I was on my internship year, I worked at a medical college and also a VA that had 2 sites. And so I worked with neuropsychologists who just within the VA worked on the spinal cord injury unit and traumatic brain injury in medical rehab. So people that have had, say, heart attacks and were recovering, and on the PTSD clinic, or the PTSD unit as well. So even within one setting, a neuropsychologist might do a lot of different things. So the spinal cord injury unit, for example, a lot of their work was bedside, where they were working with people who, struggled to get out of bed or needed assistance or just couldn't, right? Whereas when I was doing the TBI clinic, that was really cool because it was like me, a neurologist, a nurse, and a social worker all in the room, and the person would come in, outpatient, come in just for their assessment. We'd all be in the room with them at the same time. And then as soon as we were done with the assessment, we would confer as a team to diagnose them. So, you can end up doing a whole bunch of different things. You really work a lot on teams as a neuropsychologist, because typically you're going to be working with neurologists. Certainly, as a bunch of you mentioned, the different assessments in terms of brain scans. Neuropsychologists aren't doing those, right? So they'd be working with radiologists or radiological techs, things along those lines. Nurses, primary care doctors, brain surgeons in some cases, things along those lines. As a neuropsychologist, you could also end up involved in the legal system. So what sort of scenarios do y'all think that would come up in?
If somehow your patient is involved in a case maybe with workers' comp, they had a brain injury on the job, and you have to be able to step in and be like, this is the assessment I did, these are my findings, this is whether or not I believe that this person qualifies for workers' comp, or
Exactly. Yeah, Yeah, really good example. Other examples you can think of. When would we need to provide a neuropsychological evaluation for someone involved in the legal system?
Trying to see whether or not someone was actually capable of doing something.
Yeah, so one of the things you do as a forensic psychologist is you're asked to judge if whether someone was competent at the time they committed the crime, basically. Were they guilty or were they so encumbered by some sort of either psychological or neurological issue at the time of the crime that they're not guilty just because they didn't know what was going on, right? So you might be asked to do a neuropsychological assessment related to that. How about related to lots of dollars? Civil lawsuits, so things like car accidents, things along those lines. You might be called in to assess, what the level of functionality is, how much it's changed, which can be a struggle, but there are things we can do that are nice, sort of precursors for that. So yeah, lots of ways that you can be involved. All righty, so in your Kolben-Wishaw, it talks about single cell recording. Is that something we can just feasibly do on any patient who walks into our office as neuropsychologists? No, and why not?
It's looking at individual neurons, and so you can't just put things in people's brains.
Nor would you really want to, right? Yeah. We don't want to do brain surgery unless we have to, right? That's sort of usually a last resort. And so, yeah, it's just not feasible, but it is where science starts for these things. So it isn't where they got a lot of basic science going. It's often done with animals. And in particular, if they want to just look at the neuron in isolation, they tend to use squid neurons because they're giant. So, our neurons, we can't even see, right? They fit between there, but you can feel it, right? Whereas squid neurons could be like this big, right? So like I've actually seen one in the Benjamin Franklin Institute in Philadelphia. They had a whole exhibit on the brain and how they study it. And yeah, the squid neuron was like yay big. It's a lot easier to see stuff there, right? So yeah, that is a lot of how we do this basic science. So I do have, yeah, technically one cell, right? Yeah, it's like mind-boggling. And some of our neurons are actually pretty long too. So like our optic nerve that goes, out the back of our eye, like that is made up of just the axons of the neurons in the eye. So yeah, lots of really interesting things. Okay, so hopefully the sound will behave and all that good stuff. So this is just a video about, how we look at some of these things in research. MIT, how do you not have closed captions?
I'm Matt Wilson, and I'm a professor of neuroscience here at the Coronal Institute for Learning and Memory at MIT.
Give me one quick sec. Okay, those are just gonna be metas. I was trying to see if I could get the output to get there. Probably, good call. Let me turn it way down. No, that would be helpful if those worked. It should be working. Cool. All right, well, sorry, this will be a little quiet out of the computer, but I'll switch it back to the computer sound.
So I was intrigued by intelligence, organic biological intelligence, and I started looking into the brain, taking classes in that, and I became intrigued with the brain itself, and that drove me into neuroscience. I was attracted to neuroscience first through modeling. My graduate work building models of complex biological simulate brains. And so to describe technology that we use, why do we use that? Why is it important? It's important to understand basics of brain function. That is, the brain is composed of neurons. Neurons communicate with one another using electrical signals. And that is the electrical discharges, that's action potentials, and that's little voltage spikes that travel along the communication wires or axons. And it's these little spikes, little bits of information that are tracked around, billions and billions of them all the time. This is what information looks like in the brain. So if we want to understand that information, we have to go in and be able to monitor or record these little bits or little electrical discharges. And the technical.
All right, so I'm going to stop that because there's no captions and it must be hard for y'all to hear in the back. But essentially what he's talking about is doing computer simulations of neurons, right? And whenever we're simulating or trying to measure things with, do that, and then you won't hear the hum. With neurons, what we're really talking about are the action potentials, right? And not to like review too much from IntroPsych, but essentially it is when the message travels down the axon of the neuron. It has to do with ion exchange, right, in and out. The best description I've ever heard of it is like the wave at a stadium, right? It kind of looks like that. And so that's sort of electrical, but then we don't want to constantly be frying our own brains, right? So if we want to send a message to the next neuron, we're going to do it with those neurotransmitters we've already referenced. So the next thing we're going to talk about is EEG. And so I, again, have a video that hopefully will work. Hopefully it has captions.
Writing's not that easy, but Grammarly can help. This sentence is grammatically correct.
This series of instructional videos will help you to understand some of the basics of the collection process that we use. In the lab, we implement a number of methods to evaluate the brain and its underlying neurophysiology. Today, we will be learning a little bit about electroencephalography, also known as EEG.
So just quick note on this, if you've had or heard of an EKG for your heart, this is like analogous to that, but for your brain.
EEG measures the summation of electrical activity on the scalp, primarily derived from postsynaptic activity around the dendrites of pyramidal neurons in the cerebral cortex. Neurons communicate by passing an electrical signal by the movement of ions flowing in and out of the cell. First, electrical signals are transmitted from the dendrites to the cell membrane where they meet the axon hillock. Here, the summation of all these charges is used by the axon hillock, which is the gatekeeper of the neuron, to decide whether or not the signal should be passed on to the axon terminal. The axon hillock is the point where the summation of excitatory postsynaptic potentials and inhibitory postsynaptic potentials meet.
So again,
If the
pausing
summation
real
of these
quick, the messages neurons get from the previous neurons, depending on the neurotransmitter that's being used, could either be excitatory, telling the neuron fire and pass along the message, or inhibitory, tell the neuron don't fire. And so if either of those is out of whack, you can imagine all kinds of issues, right? So if your neurons are overfiring all the time, that can lead to problems. That can even lead to like apoptosis, which is programmed cell death that didn't need to happen. If you are getting too much inhibition, right, then you might not do things you need to do. So a little bit of context there.
These potentials reaches the threshold, the signal passes.
So it essentially has to like balance out, and then whichever one overcomes it wins.
The neuron has a resting membrane potential of about -70 millivolts. Voltage-gated sodium channels will open when the membrane potential becomes more positive or depolarizes. When this occurs, the sodium rushes into the cell, transmitting the depolarization down the axon. This occurrence is called an action potential.
Side note about that real quick is just So if you do have hypertension, high blood pressure, they'll typically put you on a low sodium diet. No one should ever put you on a no sodium diet. And here is one of the examples as to why, right? Sodium plays a really key role in our brains. Certainly a lot of processed Western foods have way more sodium than we need, right? But you do need some sodium in your diet.
However, a single electrical event isn't big enough to be detected by EEG, and action potentials can cancel each other out. Enter the pyramidal neuron. Pyramidal neurons are found in the most superficial layers of the brain and are spatially aligned. Thus, their activity is synchronous, which produces a larger signal that can be measured superficially from the scalp. Axons from neighboring neurons synapse with the pyramidal neurons. Chemically gated ions on the postsynaptic membrane open in response to increased concentration of neurotransmitters that bind to the proteins.
So they're like little gates that are
However, when the depolarization begins at one end of the neuron, the other end repolarizes back to negative 70 millivolts, thus creating a dipole of the neuron and conducting a current. It is important to remember that regardless of whether an action potential is reached or not, all postsynaptic potentials will contribute to the EEG signal. Every postsynaptic potential causes the charge inside the neuron to change and the charge outside the neuron to change in opposition. The summation of the dipoles created by hundreds to thousands of neurons is what is detected by the EEG. Hopefully this video gave you an introduction to EEG methods and how they work. Thanks for watching.
So yeah, essentially EEG is measuring these dipoles, which are essentially electronic activity on your brain. So old school EEG, you used to like kind of require either shaving parts of your head to stick things on there, right? Or other ways of preparing it. Now a lot of times they just have like a cap they can put on you that has the electrodes on it, and it will read just fine because the technology is better. When might you have an EEG? What types of scenarios will they use EEG for? Okay, Miranda, and then we'll. Yep, seizures. So if you are someone who has epilepsy or has seizures for other reasons, they'll often do an EEG to try to figure out what's going on. Exactly. Yeah. So it's part of a sleep study. So when you do a sleep study, they put a whole bunch of different monitors on you. And they put like stuff around your belly to measure breathing. They'll do like a pulse ox, things like that. Well, a big thing that they'll do is an EEG because they're trying to detect the waves that change throughout your sleep. Yeah, okay, that's yeah, sleep study is a big one. And kind of related to that, the other time we might use it is during anesthesia. Sometimes they will have brain monitors on to, especially for longer surgeries, to ensure that everything's still functioning well. So there are different types of waves. I'm not going to belabor them. Your book goes over them really clearly, but essentially that's what it's looking at. And essentially, because the EEG is really good at detecting these different types of wave patterns, it's really good and a really sensitive indicator of conscious states, because these change, if someone's in a coma versus asleep versus in different stages of the sleep cycle. So REM sleep, for example, rapid eye movement sleep, which is when we typically dream, our mind looks more like we're awake than when we're initially falling asleep, because dreams are pretty active. So yes, epilepsy is a big thing. We're going to cover epilepsy in a lot more detail later in the semester, but essentially some of the common types of seizures, like the overarching ones, everyone typically thinks of the grand mal seizure. This is where someone like falls on the floor and they're convulsing. And this is, it's a French term that literally means like big bad. Grand mal translates to that. And then there's also what are called the petite mal or absence seizures, little bad or absence seizures. And these are essentially brief losses of consciousness. They can look like you're just zoning out. So those don't seem as problematic, but obviously can be if they're an indicator of problematic issues going on in your brain, right? So it can provide information about the location of problems, the duration, it's not going to tell us a whole ton about structure of the brain, right? We're not taking a picture of the brain, we're reading the output of the brain. So it's not going to tell us exactly like if there's a tumor or a bleed, right, in that way. There are two other techniques related to EEG that your book talked about. One is ERP and one is MEG or MEG. I've heard it both ways. So ERP looks at brief changes in slow wave EEG signals in response to sensory stimuli. So you'll have the person do something, or you may present them with like different lights, colors, even like tactile stimulation, and see how the brain reacts. MEG or MEG records magnetic fields of neurons. It does allow more 3D localization and imagery essentially. So there's a lot of pros in terms of being able to do this in a high-tech way. But the con is that it's more expensive than doing the EEG. So I have a quick video about what MEGs look like as well. So.
Hello, welcome to the Aston Brain Centre. My name's Caroline, this is Stefano, who's the consultant, and this is Elaine. Today we're going to take you through all the steps that will happen when you come for your MEG scan. So Stefano is going to be our volunteer today, and the first thing we'll notice about Stefano is that he has taken off anything that was on his body that might contain metal. So he's not wearing his watch, he's not wearing his belt, he's not wearing his glasses, and he's also taken his shoes off because your shoes can contain small bits of metal as well. This is really important because if you're wearing any metal when you go into the MEG system, it won't work properly. So the next.
This also means you'd be limited in not being able to do an MEG, which I believe is what she's saying. It's just Google was reading this MEG because of her accent. You'd be limited doing it if you had something like a pacemaker, right? They wouldn't be able to do this, just like an MRI. So if someone has a pacemaker, other like a screw in their knee or something like that, you're limited in your ability to use MRI.
Even things as small as dental work, like crowns.
I think crowns are okay. But essentially what can happen, and I don't think the MEG is as bad as the MRI, but the MRI is a big magnet, right? So essentially it's not going to pull stuff out of your body, but it can move stuff around through your tissue, right? So imagine you have a pacemaker and then all of a sudden it starts moving around your heart. Probably not going to be good, right? Probably going to have some damage there. And clearly you don't want that. So yeah, I would have to take off like my wedding ring, my Fitbit here, all that type of stuff. Clearly you wouldn't want your cell phone in your pocket.
Next step is for us to attach these 5 little coils to Stefano's forehead. They're very small and we just attach them with tape. 3 of them go across the top of his forehead there and 1 behind each ear. So you can see I'm going to stick this on just with sticky tape like that. So it's very easy to take off after we're finished. Okay, so here goes the first one. There we go.
And again, this is nice, and EEG, modern EEG is not that dissimilar. It used to be you had to have like these giant suction cups to do this, right? So our technology keeps advancing and makes it more comfortable for the patient, more practical for the doctor or researcher.
And your ear. Oops. There we are. You can see that we've now attached the 5 coils to Stefano, 3 on his forehead and then 1 behind each ear. And the next step for us is to ask Stefano to wear these goggles. So the goggles are an important part of the next step that we're going to do. And the other thing we need is this, which is a special tool that we use to measure the position of Stefano's head and the position of all those little coils that we've just stuck on. So first of all, I'm going to measure the position of Stefano's nose. Here we go. It's the bridge of his nose. There we go. And the beep means that the computer is recording it. And his ears. 1, 2, good. Now I'm going to do the same for all his coils. Here we go. 1, 2.
Nothing sharp about this. Would kind of be
We've
like-
now finished the process of measuring the shape of Stefano's head, and that information goes from this pen to the computer.
And we use this to find out whereabouts in the brain the seizures are coming from.
Now we're all finished with our preparations, and it's time to take Stefano through into the MEG scanner. The MEG scanner is inside this room. So I'm going to take Stefano through. I'm going to ask him to take a seat in our chair, and then I'm going to slowly lift him up so that his head is inside the MEG scanner. The camera is not allowed in this room because it's made of metal, but hopefully you can see what we're going to do next. First of all, I'm going to plug Stefano's coils that we stuck on earlier into the MEG system. And then I'm going to raise Stefano up in his chair so that his head is inside this helmet here. Okay, I'm happy with that. His head is in the right position now, so we're ready to record. During the MEG recording, you'll be able to watch a DVD to keep yourself occupied. We're going to close the door on you, but if you don't want to be in here on your own, someone can sit in here with you to keep you company. They just need to remove all their metal from their body in the same way that you did before we came in. Once we're underway, you'll be able to talk to us through a microphone so we can hear you and we can see you on a video camera as well. So you never really are on your own in here anyway. I'm going to close the door now. It makes a bit of a funny noise. And now we're ready to do our recording. We're back over at the desk now, and from here we can talk to Stefano through this intercom, and we can see him on this video screen. Give us a wave, Stefano. Good. And on this computer over here, Elaine is recording Stefano's brain activity. And it's this recording that we can use to find out more about where in your brain your seizures may be coming from. So hopefully this gives you an idea of what will happen when you come to the Aston Brain Centre to have your MEG.
I really like these type of videos that are made for patients, for what it's going to be like. I think they just explain things so clearly. They don't use jargon, and you get a feel for what the experience might be like. So I have several of those also to share throughout the semester as well. But yeah, so this is, again, as you can see, similar to what we think of when we think of an EEG. But fancier. You have more technology available to you, so you're going to get a more accurate reading. You can get things like the intensity of the magnetic field rather than just sort of like how fast are they going. It's a weird analogy, but you know, in terms of slow waves. So what were the first ways we could ever study a living brain, looking at it directly? Just x-rays. You know, the old-fashioned x-rays like you get if you break a bone, or if you, you know, go to the dentist and they take bite wings, right? And sometimes traditional radiography is still used. If we just need to produce a 2D image of the brain real quick and see like what's going on, is there a bleed, where might it be? And so conventional radiography, what we call x-rays, is basically just passing x-rays through the skull onto an x-ray sensitive film. And again, we have more advanced technologies now so that this doesn't always have to actually be a like film, right? So like I know when I go to my dentist now, it used to be she had to like take the films, walk down the hall, put them in their little dark room to process, and then we look at them at the end of my appointment, right? Well, now they can just like populate it immediately to the computer screen, right? And certainly that's true with other types of x-rays as well. Different types of tissue absorb the rays to different degrees. And that is how we can sort of differentiate, you know, bone from soft tissue and see things like, oh, this bone is not how it's supposed to be, right? So we look at especially, I mentioned gross brain abnormalities like a big bleed or tumor, but also when we might use this is for something like a skull fracture, right? Just like any other broken bone. Going to kind of skip over some of the other stuff so that we can get to CT or computerized tomography. So CT is basically X-ray, but you use different angles of X-ray, right? So again, if you've ever had an X-ray taken for like a broken bone, right? They like position you and they might like do a couple different positions and do like 2 or 3 shots, but like they come in between to do it, right? In the CT, you sit down and it's just like, it's just taking different X-rays of different, almost like dissection layers of your brain. And that creates a 3D image by putting all those images together, essentially. CT cannot discriminate between gray and white matter in the brain. But you can see major issues like ventricles and major fissures, things along those lines. So it's a nice first line of taking a look at things. Sometimes it's all we need. And if someone comes into the ER, say unconscious, you would probably do a CT over an MRI unless they have a family member with them who knows their history, just because you don't want to inadvertently put someone with like, again, like a screw in their shoulder in an MRI. So let's see, quick CT scan. I like this one because it's for how to read it. Royalty free music.
I'd like to share how I interpret a CT brain. I believe interpretation of radiology study needs to follow a set of steps to ensure accuracy. So I usually start with axial set of images in the brain window. I start from the top of the brain, make sure there's no iso-dense subdural hematomas, make sure the sulci are closely abutting the inner table of the covariant. Then I go inferiorly to look for any asymmetry like mass or infarcts and hemorrhage. And also I look at the ventricles, make sure they're not dilated in the setting of hydrocephalus. The next step.
So just real quick, the ventricles are those dark black, almost like arc-shaped or kidney-shaped things that you're seeing. Everybody has ventricles in their brain. These are fluid-filled cavities. They help with things like balance, and they also help with things like maintaining the brain's homeostasis. They hold cerebral spinal fluid. So everybody has those, but what she was saying here is like if you have something called hydrocephalus, which is water on the brain, those might be much larger than they're supposed to be.
Set of important image I usually look at are the coronal images. Small subdural hematomas that are hard to see on axial orientation images can be seen on the coronal studies, like the hematoma along cerebellar tentorium. And also small infarct along the superior aspect of the cerebellum can also be seen on the coronal images much better. In general, having orthogonal
So again, just to sort of orient you to the brain, like these are the ears, those are the eye sockets that she's looking at now, whereas before we were kind of looking top down. Facing us, I think.
relation really improve your accuracy.
These are the ventricles, these dark black ones. So again, everybody has those in their brain, that's normal. But if you have dark patches like that, other patches in your brain, you might want to be concerned, right? That might be a tumor or it might be a bleed, something like that.
Because it gives the brain a three-dimensional view of the object. And if you have time, I would suggest that you look at the sagittal reformats as well, because you can look at the anterior aspect of the temporal lobe much better. You can look at the lateral aspect of it, and also you can look at the midbrain structures. And finally, I will look at the extracranial structures, the bones and soft tissues. In setting of trauma, we look for fractures, obviously. And we also look at the sinuses, because a lot of times when patients present to the ER with headache, sinusitis is actually the main cause of their symptoms. I look at the soft tissues and see if there's any scalp laceration or hematoma. And the orbits is intact. And that's pretty much it. And that is the CT brain in about 2 minutes.
Yeah, and what she was talking about in terms of like, do you have time? You know, it's hospitals can be very busy, and if you're seeing a lot of patients, right? Like, you might not have that much time to review this, which is a little mind-boggling, right? But yeah, like side note about the sinuses, I saw an article, gosh, sometime during the pandemic, so sometime in the past 18 months or so, about how they think that like migraines for some people might actually be related to sinusitis, which is really interesting. And also, if your sinuses are inflamed, it can affect things like tooth pain as well, because of, you know, just where they sit. They kind of sit here. And for some people, they actually like dip between the nerves of your teeth. I have one that does it on this side. So in October or so, when all the ragweed's out and they get inflamed, I get tooth pain right there. And I always know that's why, right? So the sinuses are something you should take into account, obviously, too. So, yeah, so that's CT. The next thing your book talks about is PET or PET. PET is really, really cool. PET is like, I don't know, it's like science fiction almost, but it's real. It uses antimatter to measure things. So you have radioactive molecules injected into the bloodstream, typically injected. You can also inhale them. And these molecules release particles that are detected by the PET camera. And the computer is going to reconstruct variations in the density of the flow of particles. And then an image appears that represents the areas of high and low blood flow produced. And so you can kind of look at it through multiple parallel brain slices, kind of like we just saw with the CT scan. So really what the PET is doing is looking at chemical interaction and flow within your brain, which ends up being somewhat structural, but it's not structural in the same way of like, here's where we're actually seeing a physical issue. What we're looking at more is what's happening with blood flow, for example, in this person's brain. It uses a subtraction method where they subtract the blood flow pattern at rest from the pattern while they have them engage in some sort of task. So we can detect things like relative amounts of neurotransmitters in the brain. It can look at degenerative processes or metabolic activities that occur during learning. And so it's used not only in diagnosis for patients, but also in research to study cognitive functioning because of this. There are some weaknesses in that it is indirect, right? We're not taking a picture of the brain, we're getting a reading of how something is passing through with the other chemicals in the brain, essentially. And because of that, if you're not careful as a researcher, you can make assumptions that are not correct about the structure of the brain. So good PET scan folks would not do that. And I am going to, I'm going to skip over the PET scan one for now. If we have time on Thursday, we'll take a look at that. But I want to make sure I get to MRI just because if you ever have to have a brain scan, it's highly likely to either be a CT or an MRI. Those are the ones that we kind of do first line of defense. MRI is also used for a whole bunch of different things, like, for example, when I worked on my internship in a breast cancer clinic, they would send them, when things were first detected with a mammogram, they would then send them for an ultrasound of the breast tissue and a full body MRI. Because what they're trying to do is see if the cancer had spread anymore, essentially. So it uses a large magnet and a specific radio frequency pulse to generate a brain signal that produces an image. The magnets are 1.5 Teslas in strength. It's super duper strong, basically. It's high resolution, so that's a big advantage over CT here. And this is the one where occasionally people will get claustrophobic because you have to lay in a long cylinder. So like my mom has claustrophobia and she's had to get an MRI before, and they help her get set up where they like put her in noise canceling headphones. They can actually play music for her, things along those lines. Do they? Oh, that's really great to hear.
One of the eyes on my back, and yeah, but they, the ability to do like a sleep mask. if you
Nice.
want.
Oh, that's awesome. Yeah, there, it used to be they just kind of shoved you in there. So I think they've learned over the years.
They highly recommend it. I don't think it's how loud it is.
Oh, it is, because it's just like clunk, 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 clunk. Yep.
I saw my last MRI, I actually could like sit. Like,
Yeah, they
like
do
that.
have
It was
seated
super
ones
cool.
now, which is really cool. And so they're more open that way.
I saw a video of an MRI machine working without the casing and like seeing the magnet actually spinning. I'm like, this is a death machine.
It
Terrifying.
feels like that.
Like
And yeah,
without the casing, it looks awful.
yeah, and yet it's a huge advance for science. But yeah, yeah, it does look, it's scary out of context for sure. Do I see a hand over here somewhere? Okay, want to make sure I'm not missing anybody. Yeah, so it is great, but again, it sounds like they have a lot of really nice techniques now to try to detract from the claustrophobia. Another thing is you have to try to lay as still as possible. And so having something to distract you can help with that too. Because if you're just laying there thinking, don't move, right? It'd be really hard. Obviously, if you're playing music, you have to make sure it's not something like too bumping because you don't want to. Like side note related to that, my choir at my church, we decided to do Zoom choir during the pandemic, and then we would record just our voices, but then we decided the last service of the year we'd do a video. And my choir director's like, don't sway, because everyone's gonna be swaying differently. And all of us were like, it was so hard to just sit there while we sang. So yeah, distraction is good. So I do want to make sure we get a chance to look at one of these MRI videos. So let me pull this up.
Welcome to this MRI patient education videotape
Again, this is
Your
the
physician
patient
has ordered
ones,
an
just 'cause
MRI.
I think they're the most helpful.
by medication condition. What is MRI? MRI stands for magnetic resonance imaging, and for the next few minutes, we'll discuss the MRI examination. You'll see some of the remarkable images produced by this type of medical imaging exam. These are MR images of the brain. They're astoundingly clear and detailed. Here, in addition to the brain, we can see
So
the
just
spinal
sort of
cord,
Thinking about this in contrast to the CT scans we looked at just a couple minutes ago, right? There is a lot more clarity. And one thing I don't remember if they mentioned in this video or not, but I want to make sure I mention is there's also what's called fMRI, or functional magnetic resonance imaging. And there, instead of focusing on the picture, it's sort of like you're getting short videos, and you do that like while someone does a task. It's used a lot in research, but you also might do it for diagnostic purposes.
sinuses,
So
teeth,
sinuses again.
and even the blood vessels. Just what makes MRI so different from other medical imaging techniques, such as conventional X-rays and computed tomography, known as CT scans? And under what circumstances is MRI the preferred imaging technique? Let's see. X-ray devices are generally used to take projection images of hard tissues like bones. CT scans take images of both hard bony tissues and soft tissue, such as the brain. Both X-ray and CT systems use X-ray beams, which travel through the body and project an image onto a photographic film or displayed on a video monitor. MRI, on the other hand, works differently. MRI uses a magnetic field to orient the position of certain nuclei in the body. The primary nuclei used for MRI imaging is in the hydrogen atom, called a proton. As you know, the body is made up of approximately 75% water. Water is 2 parts hydrogen, making the nucleus of the hydrogen atom, the proton, the most abundant in the human body. A radio wave is then used to excite the proton, which resonate and emit varying signals, which are received, digitized, and displayed as images. Different signals emitted by different body tissues are then used to differentiate individual anatomy. When tissue is damaged, its composition changes and gives off an uncharacteristic signal. So when displayed, that damaged tissue is distinguishable from surrounding healthy tissue. Once again, it's important to point out that MRI utilizes magnetic fields and radio waves. Patients are not exposed to X-rays or other ionizing radiation. On the day of your examination, it's a good idea to arrive a little early in order to complete your patient information records and to allow for a pre-examination screening.
We'll skip forward a
Clips
little bit here.
are not eligible.
Yeah.
These devices may be adversely affected by the magnetic field. Objects containing ferrous metals will also interfere with obtaining a good MR image. Therefore, it's advisable to wear a sweatsuit, clothes without zippers, snaps, or buckles, or garments provided by the imaging facility. To improve the image quality, particularly when examining the head, knee, or spine, a device called a coil is used. It operates just like an antenna to improve the signal reception. It's also possible that you may require an injection of contrast to enhance the distinction between certain tissues. This contrast is specific for MR imaging and is different from that used for CT and X-ray examining.
So that's enough to give you sort of a feel for what it looks like and what the images look like. We will kind of wrap this up on Thursday, and then we'll start talking about neuropsych assessment, which I have a lot of really cool imagery to show you about what that looks like. So I will see everybody then, although I see some of you tomorrow morning in my other classes. I know.
And next